Hello, my name's Andrew, and in this session I'm going to be talking about an overview of haematology that's tailored to critical care, in particularly intensive care trainees. I've worked part-time in ICU for a year as part of my advanced training, and I found that such a valuable opportunity to understand critical care and the unique set of problems and also unique set of interventions that we can offer in that space to preserve life and support treatment of very complex conditions. And within that, it's generally held that haematology patients, particularly those that are having stem cell transplant, are often very complicated and difficult to understand, as it can be quite a niche with a lot of evolving therapies. So what I'm hoping to do is that if you're a trainee in critical care or some area outside of haematology that does look after haematology patients from time to time, even in a perioperative capacity as well, that this will give you some kind of framework to understand more about haematology. So I'm going to talk about some of the common malignancies that will lead to critical care support, and I'm going to talk particularly about bone marrow transplant, those types and when we do that, graft versus host disease, prophylactic drugs that are used in that space, and then we're going to finish on a couple of perioperative issues, particularly around people with inherited bleeding disorders such as von Willebrand's and haemophilia. So within the big picture, I think it's really hard to have a good grasp of haematology generally, because haematology is a very broad and a very deep field, and there's not a lot of fields that are specialty medicine that have that same kind of breadth and depth at the same time. I often say that if I was designing, medicine and where things are divided into specialties, I think I would not design haematology to be as it is with this huge depth and breadth together. And it's only getting deeper and broader as time goes on, as we understand particularly malignancies and have a wider range of therapies and testing available to us. I think it's helpful to think of it in terms of malignant haematology and non-malignant haematology. Within malignant haematology, you've got the big three cancers of leukemia, lymphoma, and myeloma, and some predisposing conditions of myeloproliferative neoplasms and myelodysplasia that are still in that kind of myeloid and leukemia type space. Then there's a lot of crossover with that into the non-malignant space, but the non-malignant space has huge crossover into surgery, critical care, and other areas of medicine in general practice. Within there, I think of things like transfusion, hemostasis, coagulopathy, thrombocytopenia that is not related to malignancy, anemia, which is super common, myeloproliferative neoplasms, again a crossover with malignant or pre-malignant conditions, and hemoglobinopathies, which generally are inherited. You compare that to something like cardiology. You can have a general cardiologist, and their three main fields are interventional, which I think of as plumbing, electrophysiology, which I think of electrical, and echo or imaging, which is structural cardiology. And the particular disease group fit nicely into those three specialty areas. It's even easier if you're a gastroenterologist. You've really got luminal gastroenterology and some subspecialties like ERCP, IBD, and other issues within luminal, and hepatology. And that makes it a lot simpler as a gastroenterologist. So within malignant haematology, let's break down some of the big areas. So within leukemia, you've really got your acute and chronic myeloid and lymphoid. And we'll talk a bit about what is a myeloproliferative and what is a lymphoproliferative process and how we distinguish those shortly. So there's acute myeloid leukemia, a very potentially fatal acute leukemia, and a subset of that which we treat differently is acute promyelocytic leukemia, probably one of the best prognostic diseases to have in this whole group. Then we've got chronic myeloid leukemia, what used to be a very deadly disease and a strong indication for stem cell transplant, now controlled thanks to targeted therapies that address the specific pathophysiology of that disease. And most people with CML live for long, healthy lives. Acute lymphocytic leukemia, very common, I think the most common malignancy for children, but some that we still see in young adults in a small number. And then chronic lymphocytic leukemia, which would for sure be the most common leukemia in the older population and is generally one that does not require treatment at every stage. And often people are left with CLL for many years without any kind of problems. Within lymphoma, there's about 127 types of lymphoma. So if you're unsure and you see lots of different names, don't worry, even I get confused sometimes. I find it really helpful to think of lymphoma as being Hodgkin's, which generally has a good prognosis, generally younger patients in the mediastinal and cervical involvement, versus non-Hodgkin's. Most lymphoma is non-Hodgkin's, and most non-Hodgkin's lymphoma is B-cell. So within B-cell, which accounts for the vast majority of non-Hodgkin's lymphoma, you can think of them broadly as high grade, which is things like diffuse large B-cell lymphoma, one of the most common types of B-cell lymphoma, and certainly the most common at high grade, and those that are low grade or indolent, those which is like CLL, they don't need to be treated straight away in many instances, and they often, after treating, will be in remission for a period and will relapse sometime in the future. Some examples of low-grade B-cell lymphoma are follicular lymphoma and also mantle cell lymphoma as well. There is a less common group, which are T-cell lymphomas. They can be of the skin or can be more systemic like the B-cells. They're much rarer and they can be a little bit more complex with varying prognostic implications. Then we've got the plasma cell dyscrasias is the term that we use to look at this group, but I think of myeloma and its related or precursor conditions. There's a spectrum of disease there. A monoclonal gammopathy of uncertain significance, it's a paraprotein and the vast majority of them don't progress to myeloma. Smoldering myeloma, which is basically where you've got bone marrow evidence of myeloma but is not yet affecting organs, but generally will with time. And you can have solitary plasmacytoma, so that's the actual lesions that are there, and multiple myeloma, which is really myeloma in the bone marrow that has now spread to other areas and affecting the body. Very common condition, very slow growing, somewhat difficult to control, but many people live with it for years and years, thanks to novel therapies and autologous stem cell transplant. Myelodysplasia is really an age and sometimes chemotherapy related disorder that can predispose and devolve into acute myeloid leukemia or just frank bone marrow failure. And then there are myeloproliferative neoplasms, so polycythemia vera, which is primary high hemoglobin, essential thrombocytosis, which is effectively primary thrombocytosis, myelofibrosis, which is an overactivity of the fibroblasts in the bone marrow, and chronic monomyelocytic leukemia, which is really like a type of myelodysplasia but has some crossover into the MPN region. So within lymphoproliferative and myeloproliferative disorders, these are terms that as a trainee I didn't have a really good understanding until I started training in hematology. Lymphoproliferative disorders are those in the lymphoid family, lymphomas, ALL, CLL, hairy cell leukemia, and even multiple myeloma is technically part of that category, as well as Waldenstrom's macroglobulinemia, which is effectively a type of slow-growing lymphoma that has a paraprotein like myeloma does. They really have clinically features of lymphadenopathy and organ involvement related to lymphadenopathy, except for myeloma, and that lymphoid compression of tissues can be a manifestation, is usually a strong indication for treatment. They also have a degree of immunocompromise, and so they can have unusual infections, particularly once they start treatment. Then on the other side, you've got myeloproliferative disorders, so anything with myeloid in the name. Acute myeloid leukemia, chronic myeloid leukemia, polycythemia vera, essential thrombocytosis or ET, and myelofibrosis. That's the family that's there, and myelodysplasia is similar in there as a predisposing group. They also have immunocompromise, generally because of a lack of functional cells, but they have significant hepatosplenomegaly as a defining feature of this group, and progressive bone marrow failure, which manifests as pancytopenia, unlike the lymphoid group, which generally don't have pancytopenia unless there's direct involvement of the bone marrow with the lymphoid disease. So the initial workup I put there, when to do a bone marrow, when to do scans. You can look at this more. There's a talk that I've done in a different video that is malignant hematology, where we explore diagnostic workup of all of these conditions. There's a really important modality of testing. It's called flow cytometry, also known as immunophenotyping, that's often not very well understood. This is where we put cells, generally malignant white cells, which that's the most of our hematological malignancies are in the white cell family, through a particular cell tester that puts a laser onto those cells and certain markers that then are triggered by the laser to release certain light. And that's when we say, oh, there is the presence or absence of these particular cellular markers. And those cellular markers basically give an identity to that cell and a level, both in terms of disease and degree of maturation within the family. So you work out, okay, that cell belongs to the lymphoid family, it's very immature, it has markers consistent with acute lymphocytic leukemia. That's an immature lymphoid disease, versus a mature lymphoid disease like CLL or follicular lymphoma. Let's talk a bit about acute myeloid leukemia, which remains as the most common indication for allogeneic stem cell transplant. And these are the people that will generally get very sick and end up in intensive care or require some form of critical care intervention. This still has, and I would say that this is the last big frontier of hematology that we've yet to make big strides in the last 20 years, unlike other areas like lymphoma, myeloma, and CML, which have had quite significant advances in therapy that have improved outcomes in a really big way. It still has a really high mortality. So we're talking about in older adults, which is the average patient is 70, it's 90% mortality. In young adults, we're talking more like 66%. So still 2/3 of people with this are potentially dying after a period of time. We used to classify according to the French, American, and British classification of M0 to 7, and now we risk stratify and prognosticate, and I'll talk a little bit about that in a moment. We induce people into remission, ideally with a combination of daunorubicin and cytarabine. The cytarabine's for 7 days continuously, and the daunorubicin is once a day for 3 days. So we call that the 7 and 3 regimen. We have alternative options like FLAG-IDA, and also different versions of 7 and 3 as well that we may use, but 7 and 3 is still the cornerstone. So generally, what we try and do as we diagnose and start treatment, we send off genetic testing to help work out what's the prognostic group that this person and this patient with AML will fall into. Are they going to be in a low risk category? And the low risk group generally will respond to chemotherapy and will have a lower chance of relapse and therefore do not require stem cell transplant. Or are they in a high risk group? The high risk group are much more likely to relapse following chemotherapy and therefore will get an upfront transplant once they're in remission. And then the vast majority of people, which is about 70%, will fall somewhere into the intermediate risk group where we need molecular markers to work out whether they have a slightly more favourable prognosis or a slightly higher risk prognosis, and therefore decide whether we give them a stem cell transplant upfront or not. Here it is a little bit more detail with some of the genetic markers that we use more commonly. So you can see this low risk group, they're associated with the presence of NPM1 or CEBP alpha on both alleles or RUNX1 fusion. The intermediate group may be associated with NPM1 mutation and FLT3 ITD mutation together, and that FLT3 is usually a negative one, but the presence of the NPM1 seems to put them into the intermediate group. You might have FLT3 ITD or TKD that's a low expression alone, that will put intermediate group, and there's a few other non-specific features that will put you into intermediate. Versus the high-risk group, we think about people that have the TP53 mutation, people that have high expression of FLT3 without NPM1, people that have IDH1 and 2, and people that have RUNX1 or ASLX1, as well as just complex karyotype fits into that group as well. Those markers and the complex karyotype are more common as people get older, and therefore the prognosis as we get older gets worse, also because they usually don't have as much physiological reserve to go through the insults of chemotherapy and the complications. So if we contrast this with acute promyelocytic leukemia, even though this is a subtype of AML, we treat it as a distinct entity because it has such good prognosis, because it has a very specific pathogenesis that is targetable by treatment. So the 3-year survival in the best possible group, so good prognosis, has a 95% 3-year survival. Even the worst case of these ones, the worst prognostic group, has a 70% survival at 3 years, which is still better than young adults with AML. So it's a much better disease to have. It is actually the most fatal disease if it's left untreated, much faster than standard AML because of DIC and uncontrolled bleeding. But if you start them on treatment, that process gets shut down very quickly. The hallmark of this disease is a very specific translocation between chromosome 15 and 17, which is the promyelocytic leukemia PML gene with the retinoic acid receptor alpha gene, and that gets translocated. And that produces a fusion protein that it disables the usual retinoic acid-induced differentiation of neutrophils. And then the PML mutation itself prolongs the life of the leukemic cells and inhibits other areas of development like red cell development and platelet development, which means that you're producing lots of these immature neutrophils effectively, or promyelocytes. So we induce people to remission with all-trans retinoic acid. It's a thing that bypasses the mutated retinoic acid receptor and allows all of those promyelocytes to mature into healthy neutrophils. And we use arsenic trioxide with that, which is actually developed by the Chinese as a more natural therapy for leukemia. It works so well in this group, helps degrade that fusion protein and therefore reduce those effects. We also complement that with prednisolone, and in some more higher risk situations we use idarubicin chemotherapy. So within this family, you can kind of see the different groups in bone marrow. Again, have a look at my hematological malignancies video if you want to better understand where these different groups fit. Chronic myeloid leukemia used to be a really high indication for bone marrow transplant, but it's now, thanks to the development of tyrosine kinase inhibitors, is a very survivable condition. It's characterized by the hallmark translocation of 922, or the Philadelphia chromosome mutation, which produces BCR-ABL protein number 1. That increases tyrosine kinase activity, so you get this uncontrolled proliferation of the transformed cells, you get discordant maturation, you get escape from apoptosis that would usually help control such mutations, and then altered interactions of the cellular matrix. It's not good. So naturally, because it's tyrosine kinase mediated, if you target the tyrosine kinase, you can shut down the whole process. And we can measure how successful we are with that treatment by measuring the expression of BCR-ABL in terms of concentration. And we can do that at a very high level of accuracy to a very low level of concentration, thanks to work done here in South Australia by a CML research group. And that's now become the reference laboratory for most of the world in this area, which is very exciting. So we treat them with tyrosine kinase inhibitors. The first generation was imatinib, also known as Gleevec in the brand. And now in Australia, we generally move straight to using second generation inhibitors, which is nilotinib and dasatinib, and we choose according to the side effect profile that we don't want in the patient profile. Let's talk about bone marrow transplant now. So we started doing allogeneic stem cell transplants back in the 1970s, and then we moved to starting doing autologous transplants in the 1980s. Initially, we started doing this by direct harvesting of bone marrow cells and then injecting them directly into the bone marrow of the patient. And now we've moved to peripheral mobilization, so we can trigger the bone marrow into overdrive to release stem cells into the peripheral circulation, which they usually aren't in. And we can harvest that through a particular cell collector that I kind of think is a little bit like a dialysis machine for blood cells. And then we can collect them so that we don't actually need to do a bone marrow harvest. Initially, we used bone marrow transplant as a method of allowing high-intensity myeloablative chemotherapy, and we still use myeloablative chemotherapy for young patients, so that we can then, because it's more sensitive to the chemotherapy, it allows us to use higher doses to kill off the malignancy, but yet still return to a normal level of bone marrow production afterwards. And now we can actually, in older patients, use lower intensity conditioning with the goal of developing graft versus disease. I'll talk about that in a moment. But we have to use bone marrow transplant in remission, or the active uncontrolled disease will kill the patient before the bone marrow transplant has a chance to cause graft versus disease effect. So the indications for these are hematological malignancies that have a poor response to chemotherapy, so they won't remain in remission with chemotherapy alone. So think of that high risk group within the AML, or those that have already relapsed, so they've proven that the disease is very aggressive, and so those that have relapsed with AML need to go to stem cell transplant to have a chance at long-term survival. We also give it for a few other rarer conditions, so particularly aplastic anemia that's severe, myelofibrosis, and myelodysplasia, where you're really looking at bone marrow failure syndromes and they need to have a functional bone marrow. Surprisingly, those conditions are more difficult and have less positive outcomes in the transplant space than AML by itself. The best outcome, or the holy grail that we've discovered over time of doing this, is called graft versus disease activity. The idea that the new bone marrow that you've received from a different donor, whether it be a sibling or someone unrelated, will actually have immune effect against your leukemia or other disease that's there. And if you can have that, you've effectively got an internalized anti-cancer treatment for the rest of your life. And you can see that that is a very attractive option that's usually associated with really little side effects compared to conventional chemotherapy. Sounds pretty cool when it works, and it is. So we would look at this as increasing the progression-free survival in that high-risk group from chemotherapy alone, which is probably something like 15 to 20% to 40% with a bone marrow transplant, and sometimes better in certain situations. But however, this is a double-edged sword. It's a very dangerous treatment to give because you're wiping out someone's bone marrow and you're giving them someone else's bone marrow, and that doesn't always play nicely with the body and can actually attack parts of the body with graft versus host disease. So it's associated with a mortality of greater than 20%, even in really healthy, good candidates. So it's something that we need to be very careful. It's a powerful, powerful therapy, that both can really save people's lives and return a great level of independence and quality of life, but it is also one that comes with great danger and a reasonable mortality rate. We use autologous transplant, a much safer form of transplant of giving your own stem cells back in diseases that are more mature, because you're not giving back their malignancy. So myeloma and lymphoma are generally diseases of more mature blood cells, and giving the stem cell transplant means that you are allowing high amounts of chemotherapy and then restoring their natural bone marrow. So that's a much safer thing to do. When you're giving allogeneic stem cell transplants, there's a number of different types. So sibling donor is still the best option. That's a 25% chance if you've got a sibling that they're going to be a match. You can then have match unrelated donor. So there we aim for a 10 out of 10 HLA or human leukocyte antigen matching, or at least 8 plus, 8 or greater out of 10, but ideally 10 out of 10. And we have national and international bone marrow registries that have donors that can be unmatched and provide samples even from overseas, which is very cool. We also have umbilical cord blood, so we call them cord allogeneic transplants. We often give a double cord transplant. They're from baby umbilical cord stem cells. They're very immature, so they might not take as well, and they're a really good option for people that don't have a good match as a sibling or match unrelated donor. And then the emerging one, which is generally from use in China, but we're using them around the world now, is called haploidentical donor. So that's where you have a parent or a sibling that has a 50% match, and you can understand that the lack of the match will mean that there is potentially a large amount of immune reaction. But we've learned that we can modify that and control that immune reaction through the use of cyclophosphamide on day 3 and onwards. So 4 different types, and each with their unique strengths and weaknesses. So we carefully choose the best possible option for each patient according to their situation. We generally don't accept donors that are over the age of 70, and we generally consider that a higher mismatch, so particularly haploidentical or match unrelated donors, are going to have a higher risk or severity of graft versus host disease, but a higher chance of effective graft versus disease. Again, this idea of a two-edged sword. Within graft versus host disease, you can think of the incidence is up to 50% of allogeneic stem cell transplants. The risk factors are the mismatch, the intensity of conditioning, so those that have higher intensity actually have more likely to have graft versus host, and the source of the grafts, which we alluded to within those 4 different types. We have classic acute, which develops in the first 100 days with typical manifestations of skin, gastrointestinal tract, and liver. And then we can have persistent, recurrent, or late onset, which is the acute types that develop after 100 days or continue after 100 days. Chronic can develop at any time and don't necessarily fit the classic 3 organs. And you can have overlap syndrome, which involves bits of both. I said acute graft versus host disease typically affects the skin, the gastrointestinal tract, and the liver. It can affect all 3, 2 of, or just 1. I put the statistics there, but it uncommonly affects things like the eyes, the kidneys, or the lungs. It's very unusual, but some of them we need to treat that. There's particular grading that we do in the combination. So the overall grade is the combination of the stages of different organs involved. And although graft versus host disease is related to increased mortality, the more severe the grade it is, it's also related to the reduced chance of relapse because of this effective graft versus disease that is associated with graft versus host. So if the issue is that in these patients, they have bone marrow failure or immature bone marrow production, and then they have a host of different drugs and infections that are potentially at play. So even though you can have diarrhea or gastrointestinal symptoms, it's hard to be completely certain that that is graft versus host disease versus C. diff colitis versus chemotherapy-induced diarrhea versus other forms of diarrhea. And likewise, there's a ton of drugs and infections that can irritate the liver that can look like graft versus host disease of the liver. So you need to really ideally confirm on histology. Skin is the easiest one, punch biopsy, or if you've got a GVHD of the liver, of the gastrointestinal tract, then you do a colonoscopy to take a sample there and confirm on histology. We try and prevent GVHD, or at least immunomodulate it, using different drugs. So typically methotrexate early on, and then cyclosporin in most cases. And in cord people, we use mycophenolate and cyclosporin, or tacrolimus in some cases. And in haplos, we use cyclophosphamide, then mycophenolate, and maybe cyclosporin. So there's a combination of different drugs that we can use there. And so if you're a critical care doctor looking after them, really we need to continue, in most cases, that GVHD prophylaxis or treatment. We direct treatment towards whichever organ's involved, and it often uses methylprednisolone in more severe cases, or oral prednisolone as maintenance, as well as some other agents on top of that. So when you've got these patients, we give them a lot of drugs which are generally targeted at preventing infections or complications, and I'm going to talk about a few of them right now. So in terms of antiviral therapy, we really are concerned about varicella zoster and herpes simplex reactivation or actual initial infection in all of our patients on any chemotherapy, whether they be stem cell transplant or other non-transplant chemotherapy regimens. So for that, we put almost everyone on famciclovir or valacyclovir, or in some cases where they can't take oral, we'll use a lower dose of acyclovir intravenously. Pretty much everyone is at risk if you're on chemotherapy or have that disease. Then we think about pneumocystis jirovecii pneumonitis, or PJP. Not everyone needs this, so those that have an allogeneic stem cell transplant definitely need it. Those with acute leukemias need it, particularly ALL. Those that have high intensity chemotherapy, or those that are on greater than 20 milligrams of prednisolone for more than a month. They're the high risk population, and we generally use trimethoprim sulfamethoxazole, also called Bactrim or Resprim as the brand name, because it's so much easier than saying trimethoprim sulfamethoxazole. You can use dapsone, but there's a large cross-reactivity, and the main reason we don't use Bactrim is either for bone marrow suppression or rash. So if it's rash, we don't use dapsone. And so our main second go-to is pentamidine, because it doesn't have the bone marrow suppression effects, and it doesn't have the same rash that some people have with Bactrim rash. However, pentamidine is not as effective a anti-PJP treatment. Then we have anti-tumor lysis syndrome, so those that have high-grade tumors, so very aggressive like DLBCL, or very high amounts of tissue disease burden, ALL being one of them as well, or those that are having high-intensity therapy, will generally have anti-tumor lysis treatment for at least the first cycle of their chemotherapy, because as all of those cells die off in response to the treatment, they release urea, urate, and other byproducts of cellular death. So we vigorously hydrate some of these, and almost everybody is on a decent dose, typically 300 milligrams of allopurinol for at least the first round of chemotherapy before we drop that off. In severe cases, we use a direct inhibitor of the urate enzyme, which is rasburicase, and we don't usually continue the allopurinol at the same time, and that usually one dose will cover for a few days. Antifungals are a little bit tricky, and they require risk stratification in terms of which chemotherapy we're on. If you're dealing with transplant patients, it's pretty simple. They're all in the high risk category, and they all get the best possible treatment. So really the options are whether you have no prophylaxis, or if you've got a low risk, we use anti-candida prophylaxis. And if you're in high risk, which is generally your acute leukemias and transplant, we use mold active prophylaxis. So that's going to cover mold and yeast fungi. So to understand that, we need to take a step back and understand, in terms of humans, which of the fungi families that can affect immunosuppressed patients. And that's such the case with allogeneic stem cell transplant patients. I think broadly it's helpful to think of them as yeasts and molds, and there's a couple of other related categories, but they're the two big ones. Yeasts generally are candida. There's a vast range of them, and the particular ones within there that you need to think about are Crucei and Glabrata, because they're resistant to fluconazole. The others will respond really well to fluconazole. And then Cryptococcus is the other common yeast, and that comes in neoformans, which is usually associated with HIV and immunosuppression, or Cryptococcus gattii, which is non-HIV related. Within molds, it's helpful to think of Aspergillus or aspergillosis being the infection as Aspergillus, typically in the lungs, and then other non-Aspergillus infections, mold infections such as Scedosporium or Fusarium. These are generally, if they get in, they can't really affect immunocompetent hosts, but if they can get into immunocompromised hosts, they can be very difficult to clear, even with appropriate therapy. So you can see here, I've chosen a few of the common kind of antifungal therapies, and I've chosen to list them compared to Candida, Candida, Glabrata, Crucei, Cryptococcus, Aspergillus, Scedosporium, Mucor, and Histoplasma. And you can see that fluconazole has a very limited utility outside of Candida that's not Glabrata and Crucei, whilst Anadula extends the spectrum across most of the fungi and has some limited aspergillosis effect. Posaconazole, which you'll see is our standard use in Australia, which is mold active prophylaxis, has great yeast activity and great mold activity at the same time, and can be used as treatment level doses. And we sometimes switch to voriconazole for specific molds where it has better activity, and we measure the levels. Some cases will actually escalate to AmBisome, which is liposomal amphotericin B. It's intravenous only, and we can use that when we're dealing with very complex molds. So I think of the azoles, think of like, I think this is Danny DeVito and Arnold Schwarzenegger. Posaconazole just does not compare to fluconazole. Posaconazole is just better in every single way. Fluconazole has very limited utility. Sorry, Danny DeVito. So when we're dealing with a high-risk group, we use posaconazole. It's a more expensive drug. And sometimes when we can't use that, we might use amphotericin B IV or rarely voriconazole. The low-risk group, we use fluconazole, and if you can't use that, we might use itraconazole and anadolafungin. So when you're in ICU and you've got these patients, they're stem cell transplant or acute leukemia patients, what are these drugs that you're not maybe as used to, and what are the things that we need to think about within a critical care environment? So let's talk about posaconazole first. Actually, of all the azoles, it has the least P450 inhibition issues, which is great. And it can cause hepatotoxicity, but it's usually not too bad. But the issue is it has the least absorption of all of the other azoles. So posaconazole, when they have diarrhea or bowel edema, often doesn't get absorbed, and we need to switch to IV or an alternative agent. We generally measure trough levels twice a week to make sure that they're getting the right amount and not too much posaconazole. And in renal failure, the solvent that the posaconazole is carried by accumulates if the GFR is less than 50, and that may then alter concentrations. And if you're in hepatic failure, which is the main clearance, it may double the half-life. And again, measuring the level will help us use the right dose. Amphotericin B is a great drug for killing mold, but it's also really good for killing multiple organs if you use it over a long period of time at high doses. So it can have nephrotoxicity, neurotoxicity, hepatotoxicity, and a rash in the skin. So if any of those things happen, or particularly if you're getting renal failure, which it can cause, you want to really consider changing the drug or prehydration before giving an amphotericin infusion can really help protect the kidneys from damage. Cyclosporin is another one that we use really commonly for protection against GVHD, and that can cause nephrotoxicity, neurotoxicity, hypertension, and liver enzyme derangement, amongst other issues. So if you're getting renal failure, even though the renal failure won't change the drug level, it's the drug level that might be causing the renal failure. So we would consider either reducing the dose or changing to alternative GVHD prophylaxis therapy for that reason. Okay, let's move on from transplants now, because you're probably sick of me talking about that complexity, but hopefully what we've talked about there will give you a better framework and some reference material on how to look after those patients. If you're not sure, always call your friendly hematology registrar consultant to really clarify, should I be continuing these doses? When do you want me to do this testing? If we work together, we can get great outcomes for our patients. So let's talk about perioperative issues, because a lot of these perioperative patients with bleeding disorders come to ICU, mostly post-operatively, but some even pre, particularly if they had trauma. So if you've got von Willebrand's disease, you've got a few options depending on the severity of disease and the severity of the intervention they're undergoing. DDAVP or desmopressin comes in a 15 microgram standard dose usually, and that can be really helpful for mild von Willebrand's disease with procedures that are not of really high bleeding risk, and that releases endothelial supplies. So if they've had a test, like a DDAVP challenge we call it, with a good rise in von Willebrand activity after that test proven, we will use that. If they haven't had it tested, we generally don't use it. Tranexamic acid can also be really helpful. I'll talk about how it's used later and in a different talk, but that really kind of prolongs the life of fibrin and prevents its breakdown. And so we would generally use a dose of 1 to 1.5 grams 3 times a day, and it can be intravenous if they're not able to swallow. Generally very low risk kind of drug, we use it quite a lot in this population. Then those that have major surgery or that have more severe disease need to use the combined factor VIII and von Willebrand factor concentration, which is called Biostate in Australia. It's a blood product. It comes, depending on how you use it, it comes in a ratio where there's 1 factor VIII to 2 parts von Willebrand factor, and we actually dose it according to that 1 part of the factor VIII. We can use different measurements, but we really try and target to get the activity back to 100%, and each unit per kilo raises that activity by 1%. So we would generally dose in a 12-hourly regimen in critical situations or 24-hourly in elective surgery. And we'll target, depending on what their severity is. So if you assume that someone has severe von Willebrand's disease, they're going to have very limited factor activity, like 1 or 2%. You need to get them back to 100%. So you might actually give them, in terms of von Willebrand's, that's going to be 2 to 1. You might actually give them 40 or 50 units per kilo in the first instance, going, I'm trying to bring that factor activity up from 1 to 2% close to 100%. And then I'm going to retest at the trough level and then adjust after that with changing the dose. You can actually, in some instances, if they're still factor VIII deficient, when you fix their von Willebrand's issue, you might actually top them up with some factor VIII product as well. And very rarely we might use activated factor VII, but only as a bypassing agent when they've got refractory bleeding. We monitor generally with von Willebrand factor activity, again targeting the 100%, and then watching that factor VIII levels where we're targeting them above 50%. Let's talk about haemophilia now, and there's some similar principles there in terms of what we're targeting and using factor. So we generally try and maintain the factor activity greater than 50% because that allows us to have generally physiological levels of hemostasis. To get them above 50% for most of the time, we try and target the actual treatment to get them to 100%, knowing that once they hit 100%, they'll gradually come down, and ideally, by the time we dose them again, they're still above 50%. So in haemophilia A, the factor replacement will give them roughly a 2% rise per unit given. So if they're severe, they're like at 1 or 2% at baseline, and so we're trying to get them as a target to 100%, we will only need to give them 50 units per kilo to get them from 1 to 100 because it gives a double percentage rise per unit. And then in haemophilia B, it doesn't give as much a rise. It's closer to 1, it's 0.85. So there we'll actually just give them kind of 1-to-1 replacement. So if they're severe, they're going to be 1 or 2%. We're targeting 100, we're going to give them 100 units per kilo. And the trough is different. So even though you have to give more factor for B, it lasts a lot longer. So we check troughs at 8 to 12 hours versus in A, we check the troughs at 4 to 6 hours. So you check the level about 15 minutes post the bolus to see that you've reached your target, and then after that we look at trough levels to see how fast it's been cleared. And then in some cases, particularly for haemophilia A and B who are having an operation with an ongoing bleeding risk, we can actually use an infusion to ensure that they're getting that above 50%, close to 100% factor activity concentrate at all times. And so we start at a certain rate and then we adjust it according to the levels that are taken. So when we're doing elective surgery, that's all in acute bleeding where we're going, oh no, they've had something happen and now we need to fix the problem. When you're doing elective surgery, we can actually be a bit more precise about that testing and look at how previous replacement has worked for that patient. So we generally target the levels of 80 to 100% for factor VIII or haemophilia A, and then targeting 60 to 80% for factor IX or haemophilia B, using the same principle. If it's just mild haemophilia A and they're not having really major surgery, you can use DDAVP and even some tranexamic acid, particularly for mucosal bleeding or skin issues. There's some guidelines there. The last thing I want to talk about is a couple of specialized products that we use, which are hematological products used often in ICU. The one is Nova 7 brand name, which is activated factor 7, very expensive, generally used at a standard dose of 90 mics per kilo. We can use that to control bleeding and surgical prophylaxis in people that has inhibitors of factor 8 or 9, which is acquired haemophilia A and B, or congenital factor 7 deficiency. And we also use it in Gladensmann's thrombocythemia, which is a very rare primary hemostasis disorder. And then sometimes we use it off-label as a last resort for major traumatic hemorrhage. And they're ones where we need to make sure we've optimized their coagulation parameters, pH and temperature and calcium. Check out my trauma coagulopathy if you want to have a bit more detail around that use there. The last one is filgrastim or pegfilgrastim, but we generally use filgrastim in the inpatient setting, which is granulocyte colony stimulating factor. These are ones that trigger development and production of neutrophils by the bone marrow. They prevent neutropenia, or ideally prevent severe and prolonged neutropenia, or we might treat neutropenia with that when it's drug or disease induced. Our standard dose is 5 micrograms per kilo daily, and we round that to the closest either 300 or 480 micrograms, and usually 480 is the capped dose. And it doesn't cost, not too expensive, it's about $2 per microgram there. We generally target until the neutrophils are above 1, and then we would think of stopping or backing off of therapy. Rarely you'll see it used at a double dose, which is 10 mics per kilo, and that's where we use it for mobilizing stem cells in potential donors. So that's our specialized products. I hope this has been helpful if you're a critical care trainee.